So let's kind of give a little background here. We had an annual report recently of what the Deflection Center has done in the first year of its conception, the coordinated care pathway. What are your thoughts on some of the results there?
So the results to me show that we need to do more to actually make it successful for the people being served. And because of the fact that 92% of the people being served in the first year are also experiencing homelessness, I think it's really critical that we move with urgency to make these connections to the homeless services work, and particularly through our clean and sober shelter spaces.
Now, are there going to be enough shelter spaces to bring people to each time?
And that's one of the things that I want to do with some urgency is sit down with shelter providers and talk about a process. Do we want to have a shelter bed set aside? I think right now we have to remember we're talking about 2 people per day that are coming through the deflection center. And so the universe is small enough that I think it gives us opportunity to try this out and figure out how to make that connection so we can eventually expand and have it be more. I'd like to see more referrals start to come in. That's part of why I'm advocating for homeless service providers refer. But right now, we're talking about a pretty small population, and I think it's the right time to start making some of these reforms.
The success rate in terms of people completing deflection, there's been a lot of talk about that. What are your thoughts on it? I mean, 29% is not that abysmal compared to some of the other counties.
I think that's absolutely correct. And successful deflection right now is defined as accessing at least one referral. I would like for successful deflection to also include success for that person. Are they engaging in treatment recovery and or are they on a path to recovery from homelessness? And right now that's not a part of what the system was designed to track, but I think it's a critical next step for this deflection program, particularly after it's been operating for a year now.
So is that part of your plan is also tracking whether or not people are off the streets and in shelter?
Absolutely. So part of it becomes one, homeless services is completely disconnected from deflection. And so one step is to have deflection staff actually looking in the homeless management information system, the database, so that we can see if people are one, already connected to services and get them reconnected with their case manager, or two, get them added to the by name list if they're not currently on it. Right now, none of that is happening. The next step would be what happens for that person after they visit the deflection center. Again, right now, follow up is for 30 days and it is about them accessing a referral. I would like to see them actually connect into homeless services and or addiction treatment services so that they are in the system and actually on a path to recovery. And those systems already do longer term tracking than the deflection center currently does. So this is a both and for me. This is a yes, we're successfully deflecting people from the criminal justice system, but we should want more and we should expect more out of our county. So I want us to make that next step and make it successful for the human being.
I think a lot of people thought this was already happening in terms of, shelter being a part of this. We had talked about shelter being a part of the deflection program and referral to shelters, et cetera, and warm handoffs whenever possible. So why is that not already happening?
It's not happening because it's primarily referral based and because there hasn't been, again, that explicit connection. I used to run a low barrier shelter and I had partnerships with addiction treatment providers at the time. And I can tell you that when somebody had a relapse and they had to come back into a low barrier shelter, it was very challenging for folks to stay on that path to recovery. That's why we have to bring in our clean and sober shelter providers in particular, so that we're actually setting people up for success. I'm not saying nobody has gone through a whole treatment. We don't know. And that's part of the problem is we don't know. And so by both combining these data systems, but also making the explicit service connection. So it's not a, here, Christina, here's a referral to such and such a shelter. It's me calling the shelter and saying, hey, Christina is going to be leaving deflection today. Can I bring her over? Is her bed ready? And that's a really different approach than what we're currently doing.
Can you break down what you just said when you were talking about relapsing and going into shelter, low barrier? Can you break that down a little bit? I don't know if I was fully following there.
Sure. So sometimes, and this is historically, I think programs run a little bit differently, but sometimes somebody would have a relapse in their addiction, and they would be in a clean and sober environment. And oftentimes that means that you have to, sometimes you can't stay in that environment. And so people would then come to my low barrier shelter with the goal of staying clean for 30 days so they could get back into treatment. That kind of staying clean when you're on the streets or in a low barrier shelter is really challenging. And so what we have the opportunity to do now is somebody is in deflection. They're often accessing the sobering component, and then we can get them at that point in time into a clean and sober environment because it's more supportive. It's the whole culture and the whole community is about recovery.
So, but if somebody's just used and they get arrested and they're going to the deflection center, they're not sober yet. They would need sobering services first, and then the sobering services will plug them into a shelter, right?
And the deflection center itself could be, right? Having a PCS doesn't mean you're actively high. It may be, but that's a part of what I trust the staff on site to triage is what's next step for that person. But right now, the next step, just being a referral, is insufficient to me.
And with sobering services or in-house treatment or whatever, from what I understand, sometimes it's a referral and sometimes it's not. Like if there's an immediate bed opening in sobering services, they're supposed to give a warm handoff, right?
Well, that's in the same location. So the sobering, they're not going anywhere. They're actually in the same building.
For long-term sobering, though, they're
No, not for long term. So for long-term treatment, you actually have to go to outpatient treatment to complete an assessment before you can go to inpatient treatment. So we're asking somebody to go into deflection and then take maybe 2 or 3 additional steps and navigate services before they're actually in a treatment setting. So in addition to having access to clean and sober shelter that I've proposed, I'm also proposing that we bring that assessment into the deflection and sobering center. Instead of having people figure out how to navigate services, we bring the services to the person. And I think that shift will really help set people up for success.
how does that happen? So how are you taking the outpatient portion and bringing it to the sobering center?
That's a question I have for the actual providers is can we get folks who are either stationed at the deflection center to provide these assessments? Is it training existing staff at the deflection center to conduct the assessments themselves? I'm open to what that looks like and really want to lean into the expertise of the providers. But it's the big P policy piece, like that move needs to still happen. So I'm very open in which way we solve that problem.
So who's doing the outpatient assessments right now?
There's multiple service providers throughout our whole community. So there's a lot of our any place that does kind of outpatient clinical services, whether it's mental health or addiction, and most do both. So those are the types of sites people need to go show up at for an appointment, make an appointment, go show up, and complete the assessment.
And then that provider decides, okay, you're good for outpatient, or no, we need to find you somewhere for inpatient. Is that
Our
correct?
provider, it's partially, I wouldn't say provider decides. They're definitely a part of the picture, but there's some standardized assessments that we use in behavioral health care that really help with diagnosing somebody, which then tells you what sort of treatment path might be the best next step for them.
If they can't get into, if the assessment says they need inpatient and they can't get into inpatient, what happens next in your plan of things here?
So there is opportunity for intensive outpatient or for outpatient. I think folks will have much more success doing that if they're in a clean and sober shelter than if they're on the streets or in a low barrier shelter.
So your plan would involve getting that assessment done. If they can go to inpatient, great, they go to inpatient. If there's no room for them, then they're able to stay in the clean and sober shelter while getting outpatient, and then if necessary, move to inpatient when something opens.
Absolutely. And all of those services, whether it's inpatient, whether it's shelter, we also need to have pathways for folks, either around income acquisition, whether that's employment or disability income, as well as the ability to leave those spaces into housing, right? We don't want folks to go through treatment of any kind and then suddenly be back outside once they've completed treatment. So it's creating that fuller spectrum of continuum. I want deflection to be a front door into treatment services, and right now it's not. So that's really the big shift.
What are generally requirements for somebody to stay at a clean and sober shelter, though? Like if somebody ends up relapsing in the shelter, wouldn't they get knocked down to a different shelter?
Not generally, and that's some of what talking with those clean and sober shelter providers is. Generally, people relapse is a part of recovery, and so it's not an immediate you have to leave. There's a lot of work our providers do to kind of work with the person and decide what their next step is going to be. So the goal would be to re-engage in treatment, and to not shame or guilt around a relapse, but to offer it as a learning opportunity to move forward in their ongoing journey of recovery. And they may say that they need additional staffing or some kind of support. I'm open to that. My question is, we have to start asking what it will take to get this done, as opposed to just talking about why we can't do something. And so I've been asking to have clean and sober shelter providers convened since about December of last year, and so that's something that still has yet to happen. And that's part of why I wanted to put this out, was publicly to say these reforms are common sense. They will really help set people on a path to recovery. It will better utilize and leverage the dollars that we're investing in deflection. And also, by the way, this will be a more successful outcome for the people in our community who need and want recovery services.
Do you think this is going to increase the number of people who successfully complete deflection?
As it's currently defined, I'm not sure, because it's currently defined as accessing one referral. I do think it will help more people actually access recovery for themselves. Absolutely. A part of this has to be us redefining what success means, or having multiple points of success. Again, I do think deflection, it was set up to be keeping people out of the criminal justice system. So we can call that a success, but I don't think we can call that a success for the human person who leaves deflection, is still sleeping outside, and likely is still struggling with their addiction. So that, again, is the shift that I think could be really powerful and prove more successful for the human beings that we're trying to serve.
What are next steps for this ordinance and how much support have you garnered?
So right now we have a work session scheduled. That'll be the next step. I want to talk about it with my colleagues. I want to hear from staff, how and what we need to do to implement and really take some of those next steps. But this isn't something I want to be a 6 month or a year process. I'd like to see us make some movement in a couple of months. I think I've been saying this, like I said, for about a year. At this point in time. And so my hope is that some of this work is happening, or at least has started, so that we can get updates for what's being implemented, if anything, and then we can make plans for next steps. And I, of course, want to hear from my colleagues if there's things that I'm missing that they want to see as part of a successful county deflection program, and make sure that other commissioners' input is included. So that work session will help us define what program direction we're moving in.
When is the work session?
It is, I believe, December 18th, but I can definitely have follow-up sent to you.
Okay, so this is like a ways out in terms of actually passing.
So it's not a work, we won't pass, work sessions are just times for us to work through
Right,
policy.
that's what I mean. So if the work session
Yeah.
happens in December, then it's still a ways out before it can become an ordinance that that the commissioners will vote on.
Yes, and honestly, my hope would be we don't have to move forward in ordinance, but that this is actually something that everyone agrees needs to happen, and that we're working on it together. If we have to pass an ordinance, it feels we can do that. But I think this is something that makes common sense. And like I said, providers, I've heard from a number of them, are on board with these changes. It's just about executing them and making sure we have the capacity for the staff to make this happen.
So we can hear kind of more discussion about this in the upcoming work session. Do you expect some of the providers to be present for that, to testify on that?
I've had conversations with a couple of providers to have them either be there and offer some input and insight from their perspective to inform the board conversation. So there's a couple of folks that we're talking with that want to be there and want to be a part of helping find this solution.
All right, anything else you would add that we haven't covered?
I just think I would add lastly that, one, I appreciate you all picking this up. I think it's a critical story and it's a critical part of what the county is doing. To me, this is something that, again, taking the data from our annual report tells us that we must de-silo behavioral health care and the Deflection Center from homeless services. And so this is our path forward to actually make the Deflection program effective and functional for the people that we're serving. And that should be our top priority as Multnomah County.